life is different. We've gone into a partial lockdown again in Dublin. Wales has really kicked off, and the United Kingdom, London, could be looking at problems. But the interesting thing is, Steve, that any of the partial lockdowns that they have monitored in Britain haven't made much difference. You know, so our numbers are back down to they were going up. How's your mother?
Oh, she's not too bad. She's we're sort of on and off really with back and forth to hospital, but she we got to my little nephew's drama production last night, so that was her big goal for the week, and we managed to get there. And it was a bit unusual being in a theatre. I mean, it was only 100 attendees allowed, but yeah, it was a little bit unusual just to be in that type of social situation. But it was fantastic, really, really nice. But yeah, we've just sort of come down a little bit off lockdown. Auckland's still in some type of lockdown, but the rest of the country has decided that they're back to normal. So Patrick, the funny thing is that a lot of the tourism around New Zealand is based on Aucklanders travelling, but everyone keeps saying that they don't want Aucklanders near them. So they didn't even like us in the first place, but I think it's got worse now.
I can imagine they're probably all partying down Dunedin, are they?
Oh, Dunedin, because you've been down that way, haven't you?
I used to live down there.
That's right.
I worked in Otago, Dunedin Public. I did cardiology register, cardiothoracic respiratory. Yeah.
Yeah, because Dunedin that's the hub, isn't it? That's
It's in Green Lane in Auckland. Yeah, we covered all the Vietnamese boat people with tuberculosis. That was a big thing at the time, And then when I worked in the cruise liners, we had the Cuban, I suppose, boat people. We hit them every now and then with the ship, unfortunately, in the dark.
Oh,
but
wow.
That period in New Zealand was very interesting because your asthma rate was 6 times higher than the rest of the world, and we figured out what it was. It was phenolketonuria. I mentioned it in the book I wrote, but interesting times.
You must be missing your travel because you're every time I talk to you, you're traveling around the world lecturing or going to attend conferences. So how are you feeling that pinch in terms of not being able to travel so much?
Well, it's interesting, Stephen. The first thing is actually I quite enjoyed the lockdown. Unusually, I got the first good rest in a long time. I also wrote 3 books, believe it or not, during that period.
Wow.
Yeah, I missed going to Taiwan. I was supposed to go there. I missed going to Toronto. I missed going to Monaco. And we were supposed to do China, weren't we?
That's right.
Awards, so
yeah.
Do I miss it? Not really. It's funny. I've quite adapted to staying at home, and I've a lot of my traveling behind me, really.
It's interesting. I've spoken to a number of practitioners actually, and a lot of them actually have really taken a step backwards and said, how much they enjoy the quality of life and being with family, and they think, they've said, actually, I've heard it numerous times. People said if the borders open, international borders open again, they're more likely to travel for personal travel and keep the business travel to a minimum, because we were on a rat race. I mean, I remember I used to bump into you all over the world, and we're constantly going from one to the next, and great for networking, obviously great for education as well, but predominantly for networking, wasn't it?
And the back end of it, where we're doing all the virtual congresses. I've done one now in Las Vegas. I've done one in St. Petersburg, one in Tbilisi in Georgia. I did one in Dubai. I did one in Saudi Arabia. I did another one. God, I can't remember. I've done that many of them. And some of them I was doing moderator or chairman, and actually they're very boring. You're sitting there in front of a computer for 6 hours, and it's easier to moderate in lifetime at a conference because you can stop somebody and say, hold on, that isn't right. what you're saying, actually, I don't accept. But a lot of people have just uploaded videos, so you can protest all you want. Nobody hears you, you know, so it's...
Yeah, that's true. That's true.
Congrats on your new virtual layout. It seems to be even better than before, you know? I
Oh,
think
thank
that's
you.
really
Yeah.
wonderful. Yeah.
We've got this new piece of software that we've developed, and we're obviously on the trade show part, so that's why we've got some great animators where we thought, you know what, it's COVID free, we'll go take everyone out of space intergalactically, and we wanted to really show that, you know, the sky's the limit in terms of creativity, and we
you
thought,
were,
you know what,
as usual, ahead of the curve, and this pandemic actually suits your imagination. You, Elon Musk, and Jeff Bezos, it'd be interesting meeting us all in Las Vegas for a pint sometime, you know?
Yeah. Well, exactly. Well, it's, as I say, it's been an interesting year because there's a lot of other conferences that have sort of, I suppose, entered the market virtually. And I suppose the challenge we've had with the GVAS side is that there has been a lot of other sort of conferences. There's been a lot of free content. So we really had to change our mindset into terms of what could we deliver differently at our virtual conference. One, being global obviously makes it different because, you know, we can get some of the best experts in the world, which, like yourself. But what we changed was, rather than for the clinical program that was short presentations and voiceover on PowerPoint, we decided to just go with practitioners that could do live demonstrations of treatments. A lot of them are pre-recorded, but with that that live interaction in the chat rooms. But as you know, we sort of really make it run like a live event. We've got a fantastic business program, and it's, yeah, we call it Around the World in 48 Hours. So we will inject a lot of fun and entertainment in ours. We will allow you to go for to have a toilet break, Patrick, in between, and, you know, have some lunch. So it will be a fast-paced event, but, you know, there'll be a lot of breaks.
One of the things that I've noticed the way conferences have changed recently, and for the better, is that instead of in the beginning, where it was particular surgeons, dermatologists, cosmetic physicians showing a thing, how good am I? Look at my results, blah, blah, blah. People aren't really interested in that anymore. What they're interested in is, okay, you do it now on the stage. It's almost like a live band. Instead of playing some pre-recorded record, that's sort of, you know, you're under fire, and do it in front of people. And it's so much better because what you see is what you get, you know. And I think the rise of being open about complications has also changed the whole face of it. That didn't happen until 2011. So we had 11 years of the companies hiding it all and trying to say it never happened, you know. So that
brings me onto your workshop, controversial and all, being, you know, vascular complications. Do you want to just talk a little bit about what people can expect in November?
Sure. Well, I suppose the first thing is, because I deal with so many, I suppose, vascular complications, and I certainly have dealt with well over 100 in the last couple of years. I've gained an awful lot of knowledge as to what happens and why. And the first thing is that it can happen to anybody. We assume, because we learn anatomy, that doctors don't really get in trouble. Nurses get in trouble a little less, and beauticians cause all the problems. But we tend to forget that anatomy certainly is 3-dimension. It's not 2-dimension. And it is wonderful having knowledge of where the vessels are, but we don't really know what depth they are. And we also don't really, to an extent, know where the vessels go. Because if we look at the facial artery making its way up into the bifurcation, we say the superior and inferior labial artery, up to the alar, a lot of them just stop there. We assume they go all the way up, you know, but 34% just stop there. And then they get an anastomotic supply from another area. So it's quite startling to think that you could actually be somewhere that you think is totally safe, but you're not. I suppose that's the first thing. The second thing is, I've made it a point of never really being critical of anybody. So when a beautician comes with a patient, I treat our clinic almost like an emergency room. That sort of when they come in, you never really say the beautician shouldn't be doing this, or you shouldn't be reading this, leaving this product in this area. But what shocks me is that so many of them come in with Hyalase on board wherever they're getting it. So I suppose the first thing is absolutely a knowledge of where the blood vessels are, you know, and they're not that complicated. You know yourself that after this, you're going to have dorsal nasal, supraorbital, supratrochlear, transvasofacial facial artery making its way across. So the location of them are quite easy. A lot of people advocate, we say, the use of ultrasound. I know Hugh Cartier and Peter, some of my friends in France and Holland do. I think it sort of tends to hold up things. In 20 years of, I suppose, treating patients, I've had very minimal. So I think whenever you see this, people, you know, sort of running into problems, and I've seen in one lecture that I've seen in Russia, somebody had, you know, sort of 5 in a row. I would think that's time to go back to the anatomy books.
Yeah.
Now, the next thing is, I advocated a long time ago, back in probably 2008, we should stop using non-reversible fillers in vascular areas, and advocated only the use of hyaluronidase with hyaluronic acid fillers in these areas. And a lot of people, particularly the people with calcium hydroxyapatite, weren't really happy with me saying that, but I think that that has proven the test of time. And we have been doing this a long time, 20 years now, and people think that something like cheek augmentation just started recently. It didn't. We were doing cheek augmentation in 2001 for HIV, and we'd have put an awful lot more fillers into faces. We'd have put up to 20 mils in some of those patients' faces. I know that a lot of people tend to sort of use a lot of fillers, particularly one company advocates it, and it happens now as well. Thankfully, many things have happened. The first thing is, for a long time, I was pushing that we should be using 750 and 1500 units of hyaluronidase, and nobody would agree with me. You know, I mean, I actually had a big argument on the stage in IMCAS in Paris in 2008, 5 experts up on the stage, and I was so annoyed with them, I actually openly challenged them, how many of you have actually used hyaluronidase? Not one of them. But they were all, you know, sort of blinded to, and you know yourself, they were advocating just 75. 75 is nothing. You have to be using at least 750. Now, Claudio Lorenzo's paper changed that, but I remember the days in Las Vegas when myself, Claudio, Stephen Diane, Neil Sadek, Corey were advocating what we should use, and I was the only one at that stage saying, put in 1500. They're all saying you can't because it will dissolve your own collagen. And I'm saying, look, I've done this so many times, it doesn't, you know? So it's wonderful that all those days have changed. And now people think nothing of putting 1500 mils. The reason Americans, I thought afterwards, took a long time to convince was because their Hynelax is only 150 units. So, but ours is 1500 units. So they were, I was really saying to them, you have to use 10 bottles at a time when the most of them would have only one in the fridge, you know? And
yeah, well, big difference in. I mean, as I say, I've known you now for probably 15, 16 years, you know. I think you remember the days when I was, you know, going through Harley Street, you know, bouncing around. I came over to Ireland a few times and was selling Laress.
Some great memories.
Yeah, Isologen days, Laress dermal filler, you know. Even Laress was one of the first, you know, products we were competing with Restylane because it was a soft product, you know, versus Restylane back then. But, you know, we had our issues of whether the product was going to last long enough. And, but again, you know, we had very sort of
in that period, there was a lot of things. We'd been using Restylane since 1996, and I particularly used it from 1997. Now, America didn't take it on board. Don't forget 2004, 2007. So there's no experience of it. So originally, when we were at things like the Seafield Conference, the Jazz will remember 2006, 2007, the Americans were getting up one after another. And I'm not knocking Americans, I'm just giving medical aesthetic history as it was, you know, talking about collagen. And I'm saying, don't even waste your time. Nobody wants to hear about it. It's gone. You know, it can cause anaphylaxis. It lasts 3 months. You have to test the patient beforehand. Hyaluronic acid is the way it will go. So even back then, 2007, there was very few. And don't forget that Arnie Klein, when he originally injected Michael Jackson with Restylane, and he put in too much, whether he did or not, Michael was a bit BDD. Michael felt he did. They had to fly him to Dublin for us to take it back out again. And the most amazing thing is that when we gave him the hyaluronidase, he wanted to be knocked out for that. So we had a propofol experience with Michael as well. And it's out there in the open now. So I'm not saying anything that I'm going to be taken up on. And this is among doctors to a large extent as well. And when Michael got it taken out, and I had a phone Restylane QMed at the time, they said that nobody had done it, so there are no protocols. So we had to sort of work out our concentrations. He chickened out. He wanted it right going to see the Queen, but there was the opening at Casino Royale, and he chickened out and he didn't go to see her at all. So he came back to Dublin, and then, yeah, he later came and lived in Ireland, actually, which was good. But those were the early days, and I only mention him not from the point of view of name dropping, but he was one of the first people ever to get hyaluronic acid taken out of his face. If that's not, right. Certainly, probably the first in America, and that's for sure.
I mean, do you think? I mean, with the amount of fillers that are still entering the market, are predominantly most of them hyaluronic acid fillers, or are you starting to see new types of fillers made of, you know, consisting of other types of materials?
Look, we all know there's one company that has an awful lot of problems. I'm not going to mention it here in front of other people, and we haven't really figured out whether it's because they sell so many fillers or they just have so many problems. We had 36 problems presented. I'm reaching a stage now, because they don't seem to care, where I almost won't treat their patients. But I had another one only last week, and one I'm in the middle of dealing with. And that company really needs to face up to its problems, you know, because they sort of hide and don't address them, and it's terrible. There are different types of hyaluronic acid, and there are different types of bacteria that it's taken from. Some people use, I suppose, Streptococcus, and you know yourself, Stephen, the Streptococcus is a very dirty bacteria.
Yeah.
It has given us toxic shock syndrome. It's given us necrotizing fasciitis. It's given us potential Pandos syndrome. It's given us rheumatic illness, destroying hearts, a very, very dirty bacteria. And still we use that as the method of forming our hyaluronic acid. And for many reasons. The problem is that when we wash it down, some of the particles of strep could still be there, setting up inflammatory reactions. So there's no doubt about it, and I'm not promoting Galderma here, but their product was much better because they were able to eliminate some of this. Also, Nuuva turned around and they used, remember, one of the Bacillus subtilis, I think it was, which we just find normally in a farmyard, in hay. Doesn't really cause any problems. So the fillers are getting better and better. Do you remember, Stephen, when we started out, we had 168 different types of fillers in Britain? All our patients used guinea pigs. And, you know, the 4 or 5 we've ended up with are the same 4 or 5 that passed in the United States for FDA. But my God, the amount of trouble we had initially, and not so much with vascular occlusions, they were more later onset, but in that early period, you know, from 2000 right through to 2010, oh my God, inflammatory nodules, delayed onset nodules. It was a different time, you know. And one of the big things that happened, I suppose, was the fact that bird flu happened and mad cow disease. Both of those things changed the process of aesthetic medicine, because we were getting collagen from avian source, they were getting it from rooster's combs, and because they were getting collagen also from cattle in Texas from their hooves. Once those two diseases broke, people just did not want collagen, and that was the demise of the collagen market. For some people that were used to using it from the 90s, in the United States I'm talking about, because it wasn't that popular really in Europe, because we had hyaluronic acid for so long. And
Yeah.
so those two things. I remember in Dublin when we started off, we had patients flying in from Los Angeles and New York just to get hyaluronic acid, you know.
No, I
And
think
not a lot of them, you know.
Well, it's interesting because Amanda Cameron, who we both know very well, she was
Yes.
involved with collagen, and then she came over and then got involved, in the other filler market, and that's where I joined her, and we, that's when we sold the Lores filler. But I suppose what it really comes down to is, I mean, back to your presentation around, vascular complications. I mean, I've seen, thousands of treatments, different doctors injecting, and even the best can get it wrong, right? And would you basically give the advice really to any sort of practitioner, whether they're a beginner or an advanced person, is they really still need to have a plan, a methodology if things do go wrong, that they do have a plan?
And it's very simple. You take the ampule. Obviously, the ampule. This happens to be bacteriostatic sitting beside me. I also happen to have lignocaine for some reason. Don't know the sort of things that are on my desk. So let's say that. What do we say? Have I got something similar? Yeah, let's say that I take this. Sorry.
Looks like you've got a pharmacy back there, Patrick. It's like
I haven't really.
You've got all the goodies.
The Dr. Treacy products were getting in the way. No, let's say this is a vial of 1,500 units. Okay, very simple. You open the vial, okay, and you put in 1 ml. So suddenly you have 1 ml of bacteriostatic saline, because if you use ordinary saline, it's going to be painful. So in your 1 ml, you have 1,500 units. What you're aiming for is 75 units each time you take a shot. So you can do it 2 or 3 different ways. You have 1 ml in this. You can just make it up to 2 ml, and then every 0.1 is 75 units. That's simple. But the easiest way probably is to take a Botox syringe. See, is there some here? I'm sure there's some somewhere. Let's say this is the Botox syringe. So you've 1 ml of bacteriostatic saline. You've got your Woodford's 1,500 units, and you just suck out 0.2 into your syringe. Then you make it up again with 0.2, and so you've 0.4, each 0.1 then is 75 units. So let's say you have your occlusion here, then you inject in 10 shots around it. It doesn't have to be in the artery. If it's periarterial, it's fine. It'll make its way across. And normally take your cap time, and if you can get it down to 2 seconds, it's probably sitting up around 5 or 6, and leave the patients for an hour and do it again. I normally don't cross 3,000 units in a day. I don't think there's any need to either. And normally first we also just do a little test on the patient's arm of 20 units. Now, send them to a hyperbaric oxygen chamber, and hyperbaric oxygen chambers are really underappreciated. Hyperbaric oxygen chambers work. You start them off at 75%, make them up to 100 so that you don't blow their ears. Put them in just for an hour a day, 5 days. They're really cheap. It's only about 50 euros, maybe 100 euros, nothing more than that. And then if you get it very late, and we've got ones very late, where necrosis is already set in, what I tend to do is assume that the blood being cut off doesn't provide any growth factors, it doesn't provide any healing agents, so as a consequence, you're not going to get epidermal tissue. So what we tend to do is pull off PRP. We also use some stem cells from New Zealand red deer, believe it or not.
Oh, there we go.
Mammalian source from calcium. We put it on the area, put them under red light to activate it, and then we know with the 7 different growth factors that it'll begin to heal. You'll see it after a few days. Some epidermal tissue. You know epidermal tissue because you look close, you can see the sweat glands. You can even see maybe early hair follicles. And it'll come vascular because you're not differentiating between the vascular fraction and the sort of other growth factor fractions. So when you've got your epidermis back, what we tend to do then is use an IPL to back it back down to take the vascular fraction out of it. That's usually 3 sessions, 3 weeks apart. Excuse me. And then for the residual tissue, a light CO2 laser. And I brought back now 8 or 9 that were really serious, given up, plastic surgeons wouldn't touch them, sent home from the hospital, all scar-free, you know?
Yeah. Oh, that's fantastic. That's great news. So that actually, that brings me on to the, my next question to you, and subject is around laser resurfacing, you know, the downtime. You're one of the experts in active FX laser resurfacing. You've been doing this for quite some time. As I say, I've known it for many, many years. What's, can you tell us a little bit about, you know, during the GVAS conference in November, you're going to be doing a demonstration of active FX, and you had an interesting story as well. I think when I was talking to you when when I caught up with you in Las Vegas, you know, you've been treating different parts of the body as well and had really, really good results. So do you want to just take us through a little bit about just some of the applications? I've always thought with laser resurfacing, it's obviously the downtime's a lot longer, isn't it? And again, if it's not done correctly, then it can be a slightly dangerous procedure, but you know, with the right protocols in place.
When I started laser resurfacing, it was in 1999. And one of the big problems that we had in that era was the fact that patients got alabaster skin. So about 1 in every 10 got permanent damage to the melanocytes. And as a consequence, they remained pretty hypopigmented looking, couldn't go on holidays because they couldn't obviously tan in that area. We see it now with things like cryotherapy. So one of the big breakthroughs was in 2005 from Massachusetts Institute of Technology in Boston. And in MATS, what they did was Reliant computers came together and formed fractionalized resurfacing. The problem was they picked the wrong wavelength. We all knew that because it took 6 Fraxels, which was the original Fraxel, to do what one laser normally would do. So we had 2 big ones. We had erbium-YAG, we had CO2, and then we had Fraxel. Because CO2 was rather horrendous and it was causing this alabaster skin, people switched over to erbium-YAG for a while, but erbium-YAG left blood on people's faces, so they were an awful looking sight leaving the clinic, very scary, like Ebola gone wrong. So people like Rox Anderson came together and said, well, why don't we marry fractionalized resurfacing with CO2? And that was wonderful. That was a big, big breakthrough. And that happened 2005, 2006. So for the first time, we had a situation where you had the lasers shooting down into the skin like that there. And as a consequence, it didn't take away everything. So you had bits of the melanocyte layer left behind and they just grow across. And so scarring and melanocytes were almost disappeared overnight, which was wonderful. But then the big problem was this. The skin has things called dermal rets like this. So if you go too deep, you'll still have some epidermal tissue sticking into the dermis. And if you go too deep, then the epidermis will grow back again. The problem was the neck. The neck was like this. So the dermal rets were so small that if you went down too far here, the epidermis wasn't going to grow back. So I experimented and with treating the decolletage area. And I must say I was the first ever to work out the protocols. And I gave the lecture in Las Vegas in 2007. But what I didn't say was that poor patient took over 3 months to heal. I sort of ran it too high, but we take it like the first Irish people going to America, being afraid of the sea, but eventually somebody got there, or the Americans going to the moon, you know, and a lot of rockets fell. So by the time I had my lecture for the States, I had it down to a T, and the patients could heal in the same amount of time, 5 days. So on the active FX, and what I'm showing is you can normally run the wattage 19 to 21 watts, but when we're doing the neck, I dropped it to 12 to 14. Also, the density is normally what we call 353, but if you're running the neck, your density is down to about 2. So the density is the number of dots per centimeter. So if it crosses 5, then you're almost like back to the old ablative lasers. So we had 2 different things. We had worked out the power of the laser, that it had to be dramatically reduced almost to less than half of what you do it on a face, and then it'll heal at the same amount of time. And then the second thing was the density. So believe it or not, that lecture that I gave then, which was a bit of a world changer, to be fair, and Randy Waldman in the United States, thank him for giving me the opportunity to that. I'm giving you a version of that on GVAS, and many years later. So, and then we had eyelids, but people always did eyelids to an extent anyway. And then we moved into the backs of hands. So I'm combining in the lecture in GVAS how to resurface faces, how to do it without putting the patient or yourself in any danger, then how to resurface eyes, and how to resurface the back of hands. I had a fairly famous doctor who watched my lecture and said, Patrick, you know, for the first time, I put tetracaine or anesthetic into patients' eyes before I put in the ocular shields, because I've seen your lecture. And I said, what were you putting in before this? And he said, I was putting in antibiotics. So all I thought was antibiotics, but you know, so. Yeah.
So in terms of with laser resurfacing, I mean, is it quite likely for people to get infections? Is it quite easy? Because obviously you're going very deep.
Okay.
And people do need that.
Tina also did a paper on this, and over 400 patients, her herpetic rate was 8%. Now, when we started off, our herpetic rate was 8% as well. So I did 2 things which were different. Number one, I stopped using acyclovir. Not only was it a pain in the ass because you'd use it 5 times a day for nearly a week, which is like 35 times, but Famvir, which was once a day, ran that rate. I switched over to Valcyclovir, Valtrex, 500 milligrams twice a day for 7 days. For 8 days, 2 days prior and 6 days afterwards. Our infection rate dropped to 2%, and it has never moved off that in almost 13 years. The second thing, which is probably contributory, is that everybody mandatory gets viral prophylaxis. Now, the reason I do this is that you know yourself, if you've got herpes, you can have it for life. Well, you do have it for life. And somebody could have had maybe a herpetic lesion when they were 6, maybe 16, forgotten all about it, but they have that for life. So whether they have a history of herpes or not, everybody in our clinic goes on antiviral prophylaxis. Now, believe it or not, bacteria is very rare. And I think the reason myself is that we probably fry the bacteria with the laser when we're doing it, because I've done patients' faces that have acne, and I almost blast the laser over the acne and it seems to kill it. Now, I do sort of give them prophylaxis if it's very bad, doxycycline, usually not before, but the days after it. A tip that we used to use, because if your patient isn't healing and you've got a red face, it could be fungus. Believe it or not, fungus is more common. So the old trick that we used to do with ears, where people use 2% vinegar as acetic acid, and you can still get that in the pharmacy, we use that for the face as well. So what we tended to do was get lukewarm water if you're washing your face and put some vinegar into it and use that on your face, and that tended to stop the effect of of fungal infections. Now, if
I,
you're
I
going to
bet
have
you
a
I
herpetic
bet you it
outbreak,
stung as well with vinegar, didn't it?
no, usually it's not.
No,
You're not putting on pure vinegar. You're only putting a bit of vinegar into a basin of water. No, it doesn't tend to sting, believe it or not. And but if you normally what happens is with laser resurfacing, it's going to last 5 days. It'll peak at day 3, then it'll start getting better. Day 5 and 6, you can almost put on makeup. Now, if you have a second peak, a bit like COVID, at day 5, this isn't clearing up. It starts turning a bit purpley red, maybe little spots appearing. That will be herpes. And if you send the patient to the hospital, they'll not recognize it. Believe you me. When I seen my first couple, it took me a while. I'd recognize it now instantly on a photograph. Nobody knew how to treat it. And at the time, I worked out my own protocols. I had phoned Neil Sadek in New York, and we both came to the agreement that if all my patients are on Valtrex already, the way to treat them is probably just triple the dose. It'll blow the mind of the pharmacist because they'll be on 500 milligrams 3 times, that's 1,500 milligrams twice a day for usually a week. But any of the patients who were on it beforehand, it doesn't seem to take off. Now, you've got to be careful with herpes because don't underestimate it as an opponent, because it can cause global herpes. It can get into your brain and cause herpetic encephalitis. So it's actually a very dangerous thing, particularly if you've done a whole patient's face. The whole patient's face can suddenly turn, quite red and purpley. So for a beginner starting off laser resurfacing, it can be a scary place to be. And as I say,
I mean, Patrick, just to bring into, because obviously with the Global Virtual Aesthetics Summit that we're running in November, we really have, it'll probably be one of the biggest events of the year. And we've got a very big audience from China. We've got, Brazil, we've got, Latin America, we've got in Colombia in particular, South Africa, we've got a number of different ethnicities. Now, obviously the Asian skin, and then we've got, a number of attendees from Africa. This will be an interesting talk as well.
We got to talk about that because a high percentage of people with skin type 4 and 5 have got PIH. Now, Asians have the same skin color as themselves. They get it. Mongolians really get it. Arabic people get it. Black people tend to get it. So what I do is, and certainly Indians get it, 15% of certain ethnicities get it. So what are you going to do? So the first thing I look at is the back of their hands, okay? And if the back of the hands have got little black lines or brown lines, then I tend to say friction's enough to cause it. If I look at their elbow when it's there, I tend to say, wow, just putting there, inflammatory response to get it. Then I look for scars. If they've had previous appendixes, maybe some trauma, and there's a line in it, this is a red flag and a major red flag. Because if you cause PIH, post-inflammatory pigmentation, you probably will spend a year getting rid of it. So here's my tricks. What you do is beforehand for 6 weeks, you give them 4 to 6% hydroquinone. We make up our own hydroquinone, but you can get 4% of most of the Dr. Abaji has a good range, but we tend to sort of use many other things. Now, it's quite hard to get it in Britain at the moment just because a lot of ethnic people are trying to lighten their faces. If you also can get Pigmenorm, it's difficult to get it in Britain as well for some reason. We get that from Germany. So if you prep the patient 6 weeks beforehand, it goes down in the skin, it turns off the melanocytes, you attack them, they don't kick off. That's a good trick. Now, the second thing is this. If you're just treating melasma, cloasma, hyperpigmentation with hydroquinone, remember that it's going down. It takes 28 days for it to come back up with no melanocytes. The whole process of melanocytes is very interesting because the melanocyte is the cell that forms it. The melanosome is the little pocket that it puts into the epidermis. So people assume that it's the melanocyte making its way out, but actually, believe it or not, it's the melanosome making its way out. So it's a little supply a packet that's sort of tagged onto the cell. So this won't move up through the epidermal tissue if you switch it off at the melanocyte layer. So as a consequence of that, if I have somebody coming in with potential PIH, I prep them beforehand, and it's imperative to prep them beforehand. And I take the attitude that if the patient gets PIH after it, it's almost the doctor's fault. You've missed the fact, because nobody coming in, particularly for acne scarring, is going to be 24, 25 years of age. They'll have a mark on them somewhere that'll tell you, you know. And when in doubt, just put them on the treatment beforehand. It's so much easier electroaccutane to prevent the problem happening rather than having it treated later.
So, Patrick, look, I wanted to sort of finish off the call. I mean, just talking a little bit about you know, the event itself. You know, as I say, I've known you for quite some time, and you've been lecturing all around the world, and you know, I really appreciate the time that, you know, you're going to be giving us for everyone who will be attending GVAS 14th and 15th of November, because it's quite a futuristic conference. I wanted to sort of not even talk about clinical, but did you ever watch Star Wars or Star Trek?
Yeah, absolutely. Yeah.
So what was your favorite? Because I like to talk to practitioners on these calls about going back to our childhood, and because it is on a spaceship, I've got a few practitioners that are very excited, and they keep on mentioning about how they loved Star Trek and Star Wars. So
it's interesting. I was very interested in science from a young age, and I won the British Amateur Young Scientist competition in London. I went to Queen's Belfast when I was 15, and I won the Aer Lingus one when I was 16. So at that stage, Star Trek to me was wonderful as science. But looking back on it now, whether I've learned so much more science or not, it just doesn't gel the way it did when I was very, very young. Now, for some reason, as soon as it switched from William Shatner, I lost interest a bit as well. The plot just wasn't as far out, you know. So when I was young, I was very interested in physics. I actually taught A-level physics in a convent when I was young, and interested in cosmology, and wrote some papers on it. So this idea that there could be separate planets with life, you know, appealed to me. It's pity, you know, sort of now as we reach the later stages of life, nobody has ever communicated with us from any of these planets. Star Trek, I did that. Star Wars, for some reason, I sort of missed out on it a bit, because by the time I was watching it, we were up to 3 or 4. But I must say the CGI was good. It didn't have the ability for a deep thinker in science the same way as Star Trek did, because Star Trek always posed a mental sort of problem that they had to sort out, whereas Luke, to an extent in Star Wars, he was more or less trying to show you how he could play with computers, and C2D2 could do this and all the rest. It wasn't really getting into a scientist's head in the same way as Star Trek. So I'd have to give it to Star Trek.
So Michelle Ward said, what about Mork and Mindy? I remember Mork and Mindy I think I was just the right age. You remember that?
Of course I do. Robin Williams, yeah. I always thought Robin was a bit silly in Mork and Mindy, but anyway.
Yeah, it's a shame. It's a shame he's not here today, but
Michelle Ward, I know Michelle, she wouldn't be old enough to remember Mork and Mindy. Tell her.
I'm sure he didn't mean that, Michelle. You're not a day over 21. It's
and Michelle
has
just completed her course as a beauty therapist, so Michelle's looking for a job out there if somebody's listening. Yeah.
Oh, fantastic. There you go. A little shout out for you, Michelle. Patrick, we're going to have to wrap this up, but look, it's been an absolute pleasure. It's amazing with technology today. You're in Ireland, I'm in New Zealand, and look, it's amazing catching up with you. Really looking forward to seeing you at GVAS 14th and 15th of November. Make sure everyone tune in. It is going to be a great event. If you want to register your space pod.
Some people said, what do we offer? We offer
there we go.
IPL, MDAG, we sold our Airbnb CO2, and we queried with a PDT, or PDL rather, and so most of our work is IPL and NDAG, and we do a lot of CO2, to be fair.
Great.
We're seem to be doing like a CO2 nearly 1 or 2 a day at the moment. I don't know why, because people have the face covered up. Maybe it's because breaking out a bit, so reminding them of all the scars they have. Yeah.
Well,
Or maybe it's
what
just
you look
people
like
during
behind
lockdown.
closed doors.
Yeah, maybe it's because people during lockdown have the ability to stay away from work. Maybe that's the reason. We're also doing a lot of eyes, and we assume it's because when they look, they can't see anything but their eyes now with the masks.
Well, I think people are probably looking at themselves in the mirror more than ever being at home. I mean, I think that's the, it's all self-gratitude rather than,
And
being
I
out
see
and about.
Paloma from Glyfada has just joined. In the early days when me and you were running around London, we used to hang out in Greece, down near Glyfada. Hi to Paloma. Yeah.
We're bringing back all the memories of being overseas. I think as soon as the gates open at some point, I think I'd really love to go back to Greece or Croatia. I think those are some of my best trips.
What about
actually.
Temple Bar? I have some great pictures of you in Temple Bar.
Yeah,
Do you remember the night we met all the guys
sorry.
dressed up as lions and tigers?
Yeah,
I still have that picture, so you can't deny it.
It's always been one of my highlights, Ireland. Temple Bar. I won't be able to tell too many stories over Instagram Live, but
Stephen,
I remember
it's
one of the
totally
good stories with
closed
you.
now. It hasn't opened in, it may just be open, and it hasn't opened in 4 months, because in Ireland you can only open if you provide food. And most of those bars were more guitar bars,
Yeah. Oh, it's such a shame. Anyway, we'll see what happens. I'm sure when the old ones close, there'll be new ones that will pop up. There's always going to be opportunities, isn't there? But it's just such a shame at the moment. But hey, Patrick, we'll close this up. But really looking forward to, as I say, seeing you at GVAS.